All right, welcome everybody to the Nurse and Nurse Podcast. You got your famous Starshema. She's your famous brand nurse coach. And I'm Kevin. I work here at Central Valley Medical. We're enjoying it. We're having fun and stuff. So I hope you enjoyed today's topic. It's going to be staffing ratio in acute care and long-term care facilities. How you doing this morning, Starshema?
I am doing good. How are you, Kevin?
I'm good. I'm very good. Thank you. I hope you're doing okay.
I am. It is a lovely Saturday.
I know, right? You got my ass up here so early in the morning. I got class in a little bit, but I've been up ready to go.
Hey, you know what? But here's the thing. When you're going after your dreams and doing what you love, you do what other people don't do. You wake up early, you lean in, you show up, you have fun. Like, that's not life.
I actually woke up at 4 o'clock. I just didn't get my ass out of bed.
Yeah, I was up by 4:30. My mind wouldn't turn off thinking that I had to get on a podcast and record with you today.
Right.
And I was like, Kevin's this guy. Let me make sure I got my shit together, my numbers right, because you know what I mean?
Yeah, but I like numbers and stuff, so because numbers don't lie and shit. So I try to do research. So because I made an error in one of our first podcasts where I talked about women outrule numbers, outnumber men 4-1. It used to be that way, but I guess it's only a little bit now. You're like 51% to 49%, but you're still fucking outnumbered. So
yeah.
So why? I know, but people get crazy when you misquote shit. So why women don't run the world? I don't fucking know, but that's your fault, not mine.
Let me just say, we do run the world.
Well, y'all run my world and shit. I get my balls busted every day. So
just saying. So we running it. We're just trying to get the respect of everybody else to notice that we're running it. Like,
I need you to tickle my balls, not bust them. Caress them, not fucking bust them and shit.
Oh my gosh. Y'all, it's never a dull moment. I hope y'all really have been enjoying season 2 of the podcast. And it's just like Kevin, he's just like that guy. Like, you know what I mean? Kevin, who did you say we were? Howard Stern and Robin Givens?
So you're Howard, I'm Robin.
Wait.
You're the host, I'm the co-host. So
No.
They've been together for 40 years. They started together. They love each other. They're best friends. They're worth $50 million now. So I love
our goal. Our goal is to pass their asses up. They're worth $50 million.
Yeah. Have you ever seen their movie Private Parts?
No.
You should go watch it. See,
I'm gonna go watch it and I'm gonna study them.
Yeah, so that way you know how you and I can get together.
Yeah, because you know what I mean?
Because 50 million, we're gonna be there.
You know what? Because here's the thing. I really spend a lot of time of studying people and their behaviors and the way that they do things. Like people who are ahead of me, like people think I'm crazy, but I look at millionaires and billionaires and how they think. Like I got this book on audiobook and it's like The Millionaire Next Door. Like thinking about how they think and how they do things. Like if you want to get there, you got to start hanging out and getting into the mindset of these people. So I'm gonna have to go look up Howard Stern and Robert Givens and see, you know what I mean?
You know what the average millionaire drives as a vehicle?
Probably a Toyota,
Honda, some simple car and stuff. And I don't remember, see which one got the Warren Buffett, I think it is, one of those big wigs. His average, his house is only like $1 million. He doesn't have big fancy stuff.
And my ass out here trying to go broke and trying to buy a Bentley that I can't even afford. No, I'm just kidding. I'm just messing around.
I got a 2018 Chevy Silverado. It's paid off. It's got 50,000 miles, and I don't want to buy a new damn car. So.
Yeah, why?
I ain't doing that shit. So
one highlighted thing that I really understood reading that book, Kevin, it was talking about that when you think about department store cards of rich people and wealthy people, guess what the department store card was?
Probably like JCPenney's or Walmart or Target or something. Yeah.
It was freaking pennies.
Right.
And I was like, I'm freaking going there to get every business suit, every dress. By the way, side note, I love JCPenney's because they have some cool shit that isn't crazily expensive, but looks really nice and you look quality.
Yeah.
But I was like, no wonder why my mind think like that. I like Macy's too, but I don't shop there that much, paying hundreds of dollars for a little.
I fucking buy Levi jeans and I don't know what the hell the name brand is on Amazon and stuff. Maybe we should put it in. We'll put it in a link and stuff. But I buy Levi jeans. I have like 5 or 6 pair of jeans, 5 or 6 t-shirts, and I wear the same shit all the time.
Yes.
I don't care. I mean,
let me tell you what I did yesterday. Can I just tell you? Can I be open and honest with you for a moment? I went to Maurice's. One of the girls at work, she told me to go buy Maurice's because I was thinking about getting this belt, and I was like, where do I get a belt? Finding a nice plus size belt that's gonna fit me right. She's like, go over Maurice's. So I went over there after I left Kaiser yesterday. I had to go to a doctor's appointment and I stopped. So I went in there and I was looking, and here I go to the clearance rack. So I'm like looking, I seen one pair of jeans on the clearance rack. When I got up there, it was like $54.90. I was like, girl, it was on the $19.95 rack. And she was like, no, these ones aren't on. So I was like, all right, well, put those back. I like me a good deal on some jeans. I'm not about to pay $60 for a pair of jeans. Like, nah,
Well, I mean,
not right now.
I do. I probably pay $50 or $60 for a pair of Levi's, but they last me forever.
That's true.
But
these ones I hadn't tested the quality yet. I didn't know how long this shit was gonna last. I wasn't paying $60.
Yeah, but I've had my Levi's probably for about 4 years now, so I've got my money's worth, and they're still
Levi's
working.
are good jeans. Yeah. I've cut up a few pairs, but
I got Vans. I wear Vans for shoes. I've had the same fucking shoes for 3 years now, so
they're cool.
Yeah,
you like them? They're comfortable.
Yeah, I don't as long as they work, they slip on. I don't have to tie anything. When I first started this shit 10 years ago, I'd wear a suit and tie and try to be all fancy. After COVID hit, I'm like, fuck it. I'm wearing whatever I want. I don't give a shit.
So that's why you didn't like that one picture I stole off of your Facebook that I was going to have on our graphics. But I was all like suited up.
Yeah, but I look fat as hell and stuff.
Oh my gosh, Kevin. No, you don't. You look cool. Okay.
I like the one that you got on here. It's better and stuff. It's
just a headshot and you like
more mature. You got to be a pimp.
Wait. We not
pimping ain't easy and shit.
Hey, but somebody got to do it, right?
That's right. Look, here you go. Pimping ain't easy, baby. Pimping ain't easy.
It ain't.
I just needed some wine and whiskey, a little blunt and shit.
Wait.
Hey, look, I used to take care. I don't remember his name because it's been a long time, but I worked downtown at the facility. I'm talking about downtown.
Yeah.
And I worked in their subacute for a little bit, just like I floated there. And I took care of Snoop Dogg's cousin. I heard he passed away here recently. And so he had a poster of Snoop Dogg above his bed and stuff. I'm like, that was my dream, that Snoop Dogg would come to visit me. And I would ask him, hey, can we go fucking rolling, drinking some gin and juice, smoking a fucking blunt? I'm not chicken. I would love it. Like if Snoop ever called me, I'm like, I'm there, baby. I'll do whatever you fucking want. He's one of my all-time favorite artists. I love fucking Snoop.
Y'all I'm trying to get this visual of Kevin rolling down the street, smoking down, sipping on gin and juice, laid back with my mind on my money,
and my money on my mind. Yeah, I got it right here for you, gin and juice. I got it on my fucking playlist and shit, man.
Wait, that is hilarious. Look I'm just learning so much about you.
I love fucking Snoop Dogg, man.
Hey, I've always thought you to be this prim and proper.
I love fucking Snoop, man. He's one of my favorites.
I love it. I couldn't even imagine that would be a vibe. But you know what? Now that you got your hair, like before when we were working together, you didn't have like your hair this long.
Right, I always had short hair. That's because I was in the military. I was in the military for 10 years, 12 years total. But when I was in Iraq, Tony, that was a big song that was out. I don't know if you know who that is.
Yeah.
Tony, and then Keith Sweat. Oh shit, I can.
Oh, Keith Sweat,
I can rock with some Keith Sweat.
Nice.
Do it, baby. The time was 6 o'clock on the watch. No time to chill. Got a date. Can't be late. Hey. The girl is gonna do me. Move to the jacuzzi. Ooh, that booty. Smack it up, flip it, rub it down. Oh no.
Nurses are wild, y'all. We are some wild human beings. We have to have these sense of humors, right? I think it really makes us like
we'll fucking go crazy if we don't.
Right. You know what I mean? If not, like who knows? It's the way we cope, right?
Right.
Awesome. I love it. I love the introduction. I hope y'all really been enjoying us here on the podcast. We really appreciate y'all being here. So thank y'all for listening in. But we did get some feedback, and thank you all for reaching out to us and sharing with us things that you want to hear and have us talk about here on the podcast. Kevin's going to lead the way today on this particular podcast, but we have one young lady who wrote into us, and her concern was around staffing ratios within facilities, particularly long-term care facilities, and thinking about the safe delivery and care around it. So Kevin's going to share some highlighting information. We're going to have a conversation around that and looking at what are some of the things that California says, and then helping you be informed and aware of what those things are in operating in these capacities.
Yeah.
All right, Kevin, take it away.
Yeah, because you know I'm a damn numbers person, so I love numbers. So I'm going to start with the numbers. This is from, you can Google it. You don't even have to. Now, if you don't know what Google is, it's google.com. This happened in 1999. It was AB 394 Assembly Bill in California in 1999. It's the RN to patient ratios for hospital. I'm going to start there first. And then the final regulations were put out in summer of 2003, and then finally came out to the public in 2004. So currently, and I know that COVID's kind of put a kibosh on some of this, but COVID's been over officially, according to Governor Newsom, since last year. So don't let people bullshit you anymore. Intensive care, if you're an ICU nurse, it's 1 to 2 patients. Neonatal intensive care is 1 to 2 patients. If you work in the OR, it's 1 to 1. Recovery is 1 to 2. And that's in phase 1, because recovery has phase 1 and phase 2. And I think phase 3, but I can't remember. It's been a while since I worked PACU. Labor and delivery, 1 to 2. Antepartum is 1 to 4. If you're postpartum with mother and baby, it's 1 to 4. But if you're just by yourself with the mom only, it's 1 to 6. Pediatric units is 1 to 4. ER is 1 to 4, not fucking 2 or 3 ICUs and 2 or 3 teles for all you ER nurses who think you're fucking badass. ICU patients, oh, imagine this shit. ICU patients in the ER right next to it, 1 to 2. Trauma patients in the ER is 1 to 1. Step down is 1 to 4. Telemetry is 1 to 5. In 2008, though, now I don't know what this means. Probably they changed. So step down initial was 1 to 4, but step down in 8, they changed it in 2008 to 1 to 3. Telemetry initial was 1 to 5, but in 2008, they changed that to 1 to 4. Medical surgical units initial was 1 to 6, but now since 2008, it says 1 to 5. And then all other specialty care units is 1 to 4. The only one that's kooky, and I don't really understand this one, but makes no fucking sense, is psychiatric is 1 to 6. Shit, can you imagine taking care of all the cuckoo choose and you got fucking 6 patients and shit? Like, holy shit, that's a lot.
I need a 1-to-1 unless they're sedated.
Right? Well, we don't get a lot of psych training as nurses, so I don't even understand, like, I'm not a psych nurse, so all the psych nurses out there, the psych techs, I love you, because shit, I wouldn't know what to do. Now, here's the rub. So the lady who reached out to us, I believe she's an LVN, becoming an RN. She has worked in long-term facilities. I've worked in long-term facilities. I know a lot of nurses who come here, they work in long-term facilities. There are no patient-to-nurse ratios for long-term care. Now, you and I did some research on this. What they decided is, and I don't know who decided this shit, but you have to have, and we did the math. Well, Starshema did the fucking math. I did it because I can't count. You have to have 2.4 hours for a CNA. So a CNA has to provide 2.4 hours of care per day for one patient. Licensed nurse has to have, I think, what did I say, 3.5 or 3.4?
3.5.
Yeah, 3.5 hours per day of nursing care. And you can always write in and correct me if I'm wrong, but most nursing homes have an average of 40 to 60 patients. So if you do the math, what did you come up with? How many nurses, if we had a nursing home of 60 patients, what do we say we should have if our math is right? How many staff should we have?
If just we broke it apart into 3 different shifts, meaning that they worked 8-hour shifts in 3 different shifts, we agreed that that was 70 hours per shift. So with that, on average, considering breaks and lunches, about 7 hours of nursing, you need about 10 nurses on staff each shift to be able to meet that demand of 3.5 hours per patient.
So I messaged the person because I wanted to know if it's 8-hour shifts or 12 hours, because I don't fucking know. It's been a while. She messaged me back right now. She said they work, like you said, 3 8-hour shifts. This is what she says. We got 1 med nurse, 2 CNAs. If lucky, we get 3, and have had to do it with 1 CNA and 1 charge nurse for 38 residents. So she says that she has 38 residents. Don't know how it is everywhere else, but she's saying that, she got 38 residents for 1 nurse and 1 CNA, and that's an 8-hour shift. What do you think about that?
That's insane. Let me do some math. So 38 residents, right? And we said that they need 3.5 hours of care apiece, right?
Mm-hmm.
So that's 133. Well, that's 3.5 hours a day, right?
Yes.
3.5 hours a day. So divide that by 3. These residents only technically need that 1.16 of nursing care hours if we look at what the law says, right? So 1.1, let's just say 1.6, looking at that. So 1.6 times 38. So about 60 hours. Okay.
Does that
And
make
you
does
said
that
how
make
many nurses?
She says she has for 38 patients, she has one CNA and one nurse.
Oh, that's interesting.
Right.
So it's technically almost a 1 to 38, right? One nurse versus 38 patients. Is that what I'm
Right.
hearing?
That's what she's saying.
According to what we've read as far as standard, right? Is that if that is what stands according to what we read, then that is you can't meet that demand, right? How do you meet that in
That's what I
even
want to
giving
know.
one patient care at 1 hour? That's still too
Yeah, that's
much,
a lot.
right?
One nurse for 38 patients. So
Mm-hmm.
how does that even come out? So what is 38 times, let's see, 38, what does that come out to be? I got to do my math. Shit.
Well, if you
38
need to give one
times
hour to,
3.4. That means you need 91 hours of care for
mm-hmm,
those patients. How
yeah,
can one nurse give 91 hours of care?
and they're only there for 8.
And they're only there for 8. Let's see, divided by 8. So they're only given 11. Is that right? 11 hours? I don't know how the math works, but
But you think
that
about
doesn't.
1 to 38, so technically a person, if we look at the 3 different shifts, because they get 3.5 hours per day, right? According to
Right.
what you and I read from the source. So with that, if you divide that into 3 shifts, that's a little bit over 1.1 hour per shift in nursing care, right? Not the
Right.
CNA care, but the nursing care. So even at 1 hour each patient, right? And you got 38 patients, that's 38 hours.
Right. That's crazy though, right?
But how can she
That's
give,
quality care or even half-ass care. So
right? Or am
yeah.
I looking at it wrong? Because that's
No.
what I almost see a ratio of 1 to 38 if that's what is true and stands valid, if that's what they have on staff. So then what's happening with the patients in these long-term care facilities?
That's why they probably get bed sores, contractures. You know what I mean?
It leads to that because they can't provide that quality care to them. So with this, so how do we help the nurses who are working in these capacities? Because law says this, right? Or right, legislation says this, or this is our parameters in which organizations are going to go over, right? And use as their guidelines. How do we help those nurses who are working in those capacities? Well, what
So
would you tell them?
so I think this is the problem though. So this is what I learned. I may not be correct, but this is what I've learned. Most director of nurses who work in the nursing homes have never had much training as a director of nursing in skilled facilities. Most are like me and you. They work in the hospital. They're tired of working in the hospital, so they go become a DON because it's a job that, I'm not saying it's easy, but compared to the hospital, wiping ass is probably not that hard. It's more paperwork, more laws, more following Title 22. And so the problem is they don't know, like most, like you, I'm not putting you on the spot, but have you ever heard of Title 22?
I've heard of it before, probably just because I'm an educator, but I've heard of
Right.
it, but not saying it was something that I was versed in prior to, right?
Right. Right. But I mean, do you know what Title 22 is? What covers a lot of the skilled facilities, the special needs clients. A lot of nurses, like hospital nurses, have no idea about Title 22. So trying to go from being in the ER to a DON in the nursing home, if you don't know what Title 22 is, you got a lot of catching up to do, a lot of reading, and the manual is thick. Like nobody's going to try to read all that except me. I read that shit because I want to know. But that's the problem is they don't know these regulations. And who does the county? Like in the hospital, I don't remember what it's called, but like acuity or acuity care, they got numbers, formulas and stuff. Who does that? Who determines that?
I'm sure someone within their organization. But let me ask you, in some of these long-term care facilities, with looking at it, like I know being an acute care nurse and then like my aha moment in education is like, I knew the focus was different, but how you care for them is different. And how we look at long-term care versus acute care is different as well. Like, do they assess like how many ADLs that they need assistance with to determine their patient load? Are they a dead weight? Are they not a dead weight? Considering those type of things, you know what I mean? Like to get their type of loads versus in acute care, we understand our ICUs in the ERs 101 until they're stable. You know what I mean? Like, how do we judge that in a long-term care, since this is really like their home and we're not really we're doing maintenance type things and managing of chronic diseases versus stabilizing and
But
saving lives.
have you ever worked in a nursing home?
I worked in a nursing home
But
at
as a
a
nurse,
very, very young age as
yeah.
a nursing assistant, not as a nurse.
How many medicines does a one resident have? Like, have you ever seen a nurse do a med pass?
Oh, I've seen nurses do med pass. I went out in the clinical setting, and you think about these are chronic conditions, a lot of
Yep.
maintenance type meds. So I'm sure anywhere upward from 5 to as much as probably like 10 medications, if not more in some cases for some of these
And
patients.
so that's 90 patients in a facility. And if nobody shows up and you're one nurse having to take care of 90 patients and you got all these medications, by the time you finish med pass, the morning med pass, it's already time to go to the evening med pass. And then who does the wound cares? What about the wounds?
Well, I know some facilities now, I don't know all. I do hear some facilities have wound nurses that come in and help support with wounds and dressing changes, things of
Let me
that nature.
message her ass. Let me message her ass while you're talking, and I'll ask about that. Because you're right, they're supposed to be. Does your facility have a wound nurse?
Yeah, because I know one particular person that I used to work with at a facility. I know that they go out to other facilities and help manage the wounds for those particular patients.
Yeah, they're supposed to, but they don't. The problem is this: most nurses aren't taught finances. And so if you work in a nursing facility, like a skilled nursing facility, they get a one lump sum for that patient. And I don't know what the numbers, I'm just making up numbers, but let's say that we admit your great great grandma in a nursing facility. That facility gets, let's say, $10,000 a month for your great great grandma. So whatever we fucking do for her, we get 10 grand. So if we need more care for her, you get 10 grand. So that's where part of the issue is, because most nurses come from the hospital. They don't know what reimbursements rate or how to get better reimbursement. They have to learn that on the fly and stuff. Does that make sense? So what's this?
It does. It does.
I texted one of our people that we know in our hospital, and they called their acuity thing. It's called NEDOCS now, NE-DOCS. And I asked her, I said, is there a class that they teach you how to do this? She said, nope, we just learn it ourselves. So what does that tell you?
That they need some formal education around how to use it to make sure the tool is being utilized correctly.
So if it's not utilized correctly, what does that mean for reimbursement or staffing?
It's probably not getting the max amount of reimbursement or not being done as accurately as it could to make sure that we have the right amount of staffing to support our reimbursement levels.
Has the right amount of what?
Staffing, because that's what drives.
I wonder if that's done on purpose, though.
I don't know.
Oh, you get where I'm going with that?
I get, yeah.
Because if you're not teaching the managers how to use these tools correctly, so you have appropriate staffing, that means you don't have as much staffing, which means your budget is lower and you're saving money for the facility, but you're not doing what's best for the nurses or the patient's care and stuff.
That's an interesting angle.
You get what I'm saying? Well, I don't know if you know this, but a lot of managers and directors, and I don't know about nursing homes, but in the hospital, a lot of managers and directors, they get bonuses if they keep the pay down of the staff and the supplies down. Whatever your budget is on your floor, if I keep it down below what we're authorized, I get a bonus on that.
Oh, wow.
That is, to me, counterintuitive.
Yeah. Like, let's save the money. It appears to save the money here, but let me give you more money over here. And where are we looking at the overall?
So this lady at her facility, she responded back, she said, no womb nurse. They go to the womb center or other places for appointments. I don't think any facility, a nurse that is just for wombs. I disagree, because I've seen womb nurses too. She says usually it's a charge nurse that does the treatment. So do you have a charge nurse and a floor nurse? But that goes back to what we talked about earlier in nurse burnout, because if you have a charge nurse and she's just being charged and you're struggling on the damn floor, why not get your ass out there and help?
Right. I agree.
That doesn't make sense to me. So
no, not at all. So what do we tell these nurses who are out here, who are operating in these capacities? You know, it seemed like they're reaching out, they're asking for help, and, you know, they really need some support. So what is it that's going to help them?
I know nurses aren't going to like this, but read the damn regulations. Start doing your homework. Go to the Board of Nursing, the BRN, the BVNPT, read Title 22. Educate yourself. If you're not educated and you don't know the rules and the regulations, and we back to one of our old podcasts, and you don't know the policies, how are you going to navigate the system that's abusing you.
Exactly. Wow. And then we got to know what we're getting ourselves into, right? Too.
Right.
Like sometimes we blindly accept positions and jobs and organizations and not really realizing what it all encompass. And we may use our acute care background thinking that the long-term care works the exact same way when it
It
does
doesn't.
not.
Right. That's right. That's exactly right. If you're in long-term care and you're a nurse, an RN, LVN, you should know what Title 22 says. Because I do this, I take care of special needs adults. I write care plans for them. Whoever thought I'd fucking make a living doing care plans. But I write care plans for special needs adults, and I had to eat, sleep, and drink Title 22. That's how I learned about it. So I think every nurse should read Title 22. So that makes sense. But I got my green screen on. Everybody keeps walking behind me and shit. So, you know, we're getting, it's okay. Don't worry about it, baby. I love you. Come here.
I
Come here
love
and give
it.
me a hug. Come here and give me a hug, baby. I'll let you see why I'm doing my podcast. Come here, don't have a look. Right here, look at this.
Oh, good morning.
This is the reason why I'll be fucking 65 and still working and shit.
That's all right. Tell them no, you won't be 65 and working. We're gonna find you a way to increase the wealth that you'll be out of here by 60. How about that? We're gonna get somebody else to do the work and you just gonna sit home and take the income. How about that? That's goals right there.
All right. So she did say on one shift there's a charge nurse, a med nurse, and 2 CNAs for 38 patients. But what does the charge nurse do? See what I mean? That's what I don't
Well, they're
understand.
supposed to be in charge of the team. They're supposed to be the one that's in charge of the entire patient load, right? That's one of their responsibilities to make sure the needs of the patients are met in a time and efficient manner. And, you know, I think it just really just takes the time to explore what do these different things mean in different organizations. Because for me, an acute care charge nurse can mean one thing, but in a long-term care facility, what they do may be something completely different. So I think about this, and I think her concern is really legit. And I think it's a big thing that's out here in the world today with nursing. But I think that we also got to be informed when we take on these roles and even becoming a nurse, right? You know, we think about nursing as this one thing, but thinking about the capacities that we want to work in and looking at the laws and guidelines behind these different organizations is important to make sure you are informed in choosing where you want to work and which capacity you want to work in.
Yeah,
I
but
think that's a big thing.
Yeah, but they can tell you one thing when they hire you and do another one when you're actually on the floor. Because you know the place that you and I used to work, we used to have what's called a float nurse. I don't know if it's still there. The float nurse would be the one relieving you for break. Right before I left, they got rid of the float nurse. So I would have 5 patients, you would have 5 patients, and they would want me to relieve you for lunch. Now, how many patients do I have?
10.
So is that legal?
Not technically according to guidelines.
So then why would you as a nurse accept those other 5 patients? Whose fault is that?
The nurse who accepted
Because they won't say no. Right. I'm kooky now, you know, people make fun of me, but you know, that's what most white people do. We get to work 30 minutes an hour early and shit. I would always come to work an hour early. People would laugh at me. But what I did was I'd walk around and I'd look and see what's going on. And before I got my assignment, I would look and see what was a mess and what wasn't a mess. And if you try to give me some kooky shit, I'd be like, I'm not doing that. You better fix that. And so some nurses just accept an assignment blindly and never ask questions. But once you accept the assignment, what does that mean?
You took a responsibility of it. You're saying once you accept it, saying that I can do what is required of me, you assume the role.
What do you do? What do you do? It's hard though. Think about this. If you work in the ED and you got 4 patients you're assigned to, could you get your assignment in the huddle or they write your name on the board? Yeah, go ahead. It's okay. How can you go and see the patients before accepting assignment? Does that make sense?
Typically we don't. Yeah.
Sure you do. Think about this. Think about where you and I work. I said, Starshema, you're going to have room 32, 31, 30, and 29. And you said, okay, Kevin, what did you just technically do?
Agree to take the assignment.
Right. So then you have to say what?
Let me go check this out before.
No, but I really mean that. But if people don't do it, what does that mean? You just accepted assignment and you don't know what you're about to get yourself into. And once you've accepted assignment, now you're screwed. Because if you say yes and the assignment's a shithole, and now you're like, I don't want to do this, you can be in trouble for what?
If you say, say it again. You said if you accept the assignment and you don't want to do it, abandonment?
Yes, see what I mean? So that's why nurses got to be a little bit more aware, go and work a little early. And, you know, I know people don't like that idea, but at least you got to assess what's going on because it's your license. You don't have to take this sitting down. Like we got regulations for a reason, and evidence proves that these staffing ratios do what? What do staffing ratios do?
They're supposed to, one, safety of the patient. They're supposed to
Oh, imagine that, safety of the patient. What a
Yeah.
fucking novel concept, safety of the patient.
Right. That's what they're there for, right?
I know, but that's what I don't understand this stuff. So it just
Yeah.
makes me crazy. I'll look at this. I'm going to read this to you. It's federal and California nursing home staffing requirements. Many families are surprised to learn that there are few requirements for nursing home staffing. Now, under federal law, Medicaid and Medicare certified nursing homes, which most nursing homes are, they got to have a full-time director of nursing, a licensed practical nurse, which is an LPN or LVN or an RN, has to always be on duty.
Mhm.
A registered nurse has to be on duty at least 8 hours a day, 7 days a week.
Mm.
So if you don't have an RN on duty 7 days a week, at least 8 hours, you're already in trouble. Now, it says this can be the director of nursing too in smaller facilities. So if the director of nursing is an RN, he and she can play dual roles and stuff.
Gotcha.
There are no federal requirements for staffing ratios in nursing homes for certified nursing aides or nursing staff. Federal guidelines fail to set a nurse-patient ratio. So nursing homes are only, listen to this is crazy. Nursing homes are only required to provide at least 75 hours of training to CNAs to provide sufficient staff and services.
Wow. So that's like 2 weeks of training.
Right.
A little bit less than if you did 8 hours.
Now, the recommendation, I don't know if this will ever happen because nobody's going to want to pay for this because that means your taxes will go up. The federal government has issued recommendations for nurse-to-patient ratios, and this is in nursing homes. This is not hospitals. So if they're going to do this for skilled facilities, what should happen in hospitals?
Right.
The recommended ratio for skilled nursing facilities is 1 registered nurse, not LVN, but registered nurse for every 5 patients. Look at that shit. Under these guidelines, and yes, you heard me right. 1 registered nurse for every 5 patients in a skilled nursing facility. Right? That's their recommendations. So if that's 1 to 5 in a nursing home, which the patients have less acuity and they're just basically people put them there to die and shit. What does it say for us in the hospitals?
Right.
So under these guidelines, a nursing home maintaining minimum federal nurse staffing levels would only provide a resident with about 20 minutes of care a day.
Well, that kind of supports
Right.
that kind of supports the numbers, right? That we kind of calculated up in relationship to that.
That's crazy.
20 minutes. That is insane.
I know you love your granny, but she only needs to get 20 minutes of my time. Now get the hell out of here.
Right.
That's crazy though.
And that is crazy. And to think about that, but I think a lot of people don't understand that with going into that. And I think sometimes us as nurses, we want to go in with the thing of like, let's change this, let's do this, it has to look different. But really, we got to look at what really is the standard that's out here and figuring out, is that something of where you want to operate in and make a full commitment with deciding, yes, this is where I want to go, or no, it is not where I want to go. But we can't bring in other experiences and then expect to change what has already been out there and outlined. We'll waste our time. We'll beat ourselves up. We'll burn ourselves out. It's like essentially talking to a wall because it's always been doing what it's doing for all these years. You know what I mean?
Right.
With that. So that's interesting. I just learned something today because not that I've never been really interested in the long-term care aspect of it, but it's just really interesting to see that dynamic and that shifting and really what the standard really looks like.
So I'm going to text this to you so you'll know. I'm going to copy this, but do I have your number?
You should. If you don't, then that's an issue.
I probably have it in there.
It hasn't changed in 20 years, so I don't know. I'm just joking, Kevin.
Put it in the chat box. Okay. Nobody can see that, right?
No, it's just us. It's just us, yeah.
Yeah. So I can text you this information here. Oh, maybe I could
put it in a private chat.
No. So let me just copy and paste it in the private chat. How about that? I'll do that. That's easier. And then I had to find your phone number because I don't have it in my phone. All right, there we go. This is from somebody we know. She just sent me that. That's from the hospital. So it said, I won't read it out because I don't want, people might know and stuff, but that's another thing. So that's one thing, like if you have a patient that's in the emergency department and they are actively being transcutaneous paced, should that patient be a one-to-one patient?
They should be. They're unstable.
Even if they're not unstable, why should that patient be a one-to-one patient?
They can change at any minute.
Right. See what I mean? So, but what will happen though? What will your charge nurse say?
Probably that they're that they're okay. You can do 1 to 2.
Right.
No, 1 to 5, 1 to
1 to
4.
5
No.
is there. Yeah, but the problem is if you don't, I mean, I get it. I understand we're short-staffed, but to me, if you're going to do that, you're going to put your license at risk. You should say, hey, I want a sitter that's going to stay in this room to watch this patient to come and get me if something happens. Somebody that has CPR knowledge that can start CPR. Because what happens if the patient stops working? Or what happens if the machine malfunctions? What are you going to do?
Right.
You know what I mean? So
yeah, it's crazy out here. And I think for us as Kevin, like, I think what being consistent around the podcast and just in the things that we've been talking about here and having the real straight talk around it, I just hear a lot of like being informed, and being educated. And I have to say that you totally stretched me in areas where I feel like I'm like, shit, I just kind of took it for what it appeared to be and wasn't really informed. And I think as nurses, for us to really be able to drive change and impact healthcare in a certain particular way that we want to, we're informed of what is the laws, what are the standards, what are all these things that are out here to make sure we're making informed decisions, providing quality care, knowing what our boundaries are, and then trying to change from that space versus a feeling, or I feel this way and I feel like they're doing this and I feel like I'm doing that, having real statistical data.
Yeah, because most people have no idea, what the law is, what the ratios are. So this goes back to a previous podcast I think we talked about where your charge nurse tells you, oh, you can take 1 to 6. Well, who is she? Does she know what the ratios are? Does she know the rules and regulations, the patient staff? I encourage every nurse when they get a statement from the charge nurse or a seasoned nurse to say, I want to see that in writing. Let me see the policy. What's it say? Where did you get that number from? I challenge people to do that because I bet you most charge nurses don't know. I bet you most managers don't know.
True.
They're just being told what the big wigs upstairs tell them to pack their budget and stuff so they don't have to worry about paying the overtime and stuff.
Yes, y'all. I hear be informed, be informed, be informed. Don't take them for their word, y'all.
Yeah, don't take them for their word. That's right. So,
absolutely. All right, Kevin, you want to wrap them up? You want to send them away? I know you got things you got to do this morning.
I know that was kind of a short podcast. I'm sorry for all the people in the background running around, but I got yelled at. But maybe we'll have to start a little bit earlier so nobody's in the way.
We got 40 some minutes of good content. Okay. We did amazing.
All right, you guys. I appreciate you guys taking the Nurse and Nurse podcast with me and Starshema. We hope you have a good day and stuff. I love and stuff. So, yeah. Thank you, Starshema, for taking your time. Visit us at morethancpr.com. Visit Starshema on Facebook at Brand Nurse Coach or Instagram and stuff. So,
absolutely. Thank you, Kevin. Thank you for another great episode here on the Nurse to Nurse podcast. I'll talk to you soon. Take care. Bye.